Welcome, everybody, and thank you for joining us again. It's been a long day today with lots of sessions, and it's really amazing to have your participation and your questions, your debates, and your comments also on social media, and obviously your likes. Much appreciated. Thank you so much. We are now here with Dipak Kalra, President of the European Institute for Innovation through Health Data, but more known as IHD. Dipak, it's really great to have you here, and the floor is now all yours.
Thank you so much, Paul. And can I apologize to all of you in the audience that I'm really sorry that I'm not with you in person. I so much wanted to be with you and was looking forward to it, but I needed to have an operation yesterday, which has gone very well. And I'm going to be in full shape soon, but it meant I couldn't come with you in person. However, a number of the minute takers from the sessions have been sending me key points. And so what I'm going to take you through is some summary points of what seems to be surfacing from the conference so far as a lead-in to the grand debate that Matt Sundgren, my dear colleague, long-standing colleague, will chair. So firstly, I'm going to go through, it's a series of bullet point slides. The first heading I'd like to take you to is trustworthy and GDPR compliant systems. So what are some of the messages that have been surfacing? That the health data ecosystem is a complex mix, and we have to enable those data flows to ensure that there is complete, an important characteristic of high quality data for care to individuals, but also unbiased learning. There is, and it was highlighted, I think, in a couple of the sessions, still confusion, inconsistency in the kind of safeguards that are needed for GDPR compliance, especially for things like pseudonymized data. But unless we have trustworthy systems and trustworthy use, we won't get good quality data that we badly need. And the sense of the meeting that was discussing this point is that we need to have both a market pull and a market push. And what I have done is summarized here some calls to action that I think seem to be surfacing from the meeting. The market pull call to action is that policymakers, regulators, DPAs, DPOs, and procurers must be precise and aligned with each other and across Europe on what GDPR compliance means in the context of health, what safeguards are expected of ICT products, services, and their users. And these have got to be translated into formal certification criteria. And from the push point of view, ICT companies must value the trustworthiness of their systems as one of their key unique selling points. They must take pride in their governance, security, quality, and be positive about certifying their products against these criteria. Then when we come to AI, I think we have to recognize that AI is a very challenging customer for health data. AI needs fine-grained data, and it needs true data values. And the challenge for anonymization is it often distorts the data values, blurring, rounding, and so on, that doesn't make them true and has a risk of suboptimal AI. The AI of today has to make do with whatever data can be obtained, varying quality, varying accuracy. And we do place demands on the AI developer to be transparent about data biases, but they don't always have the insight into what biases might exist in the data where it originated, for example, which patients were included in a data set. But we have to have reliability to be confident in using the data. That's absolutely sure. So if we do want reliable AI algorithms, and if we want transparent and interpretable AI, then the community itself, the AI community, has needs too that we have to give recognition to, that they need standardized data quality labeling. And so the call to action for AI really is, first of all, on decision makers and data scientists to work together urgently on a European standard for data quality labeling, so that AI can then follow on and be transparent in things like bias. And also a separate point that surfaced in the meeting on AI, the session on AI, was that actually there is a real need for the AI community, especially the SMEs who have limited access to expertise, to have help with understanding the AI regulation, and in particular, what are the instructions for them in the health context that they need to do in order to comply with the AI regulation. There is a knowledge and understanding gap and a good practices gap that needs to follow on from our very valuable and important AI regulation. There was also a separate set of calls to action that emerged from the clinical research sessions, and I've tried to summarize these here. You must understand this has all been hasty summarization done in near to real time, that the clinical research community, that is pharma, med tech, big tech, and AI, must work in partnership with healthcare providers on a common vision understanding of what data quality means, because they actually have different needs, and they've got to align together on what will be their common ambition, how to assess it, sorry, that's a typo, assess it, and how to achieve improvements in data quality. And then they've got to work together on business models to co-finance the investments needed. And Mats, this is a hook for you to pick up on with your panelists shortly. ICT companies, especially EHR systems, must build in, and I would love this to be a phrase that we champion, data quality by design. We're familiar with data protection by design. Let's have data quality by design so users find it easy to enter high quality data. And perhaps I should have added to this bullet, users find it difficult to enter poor quality data. Let's have systems that really help that. And it emerged from the group that was discussing this, that really we need more investment in automation tools that facilitate the previous bullets, really help make data quality something that is easier to enter in routine healthcare, and especially recognizing that it's not appropriate to place additional data quality burdens on clinicians. Clinicians need tools to help them automatically enter the best possible data they can. There was also some important points from the data facilitators session that actually it's quite hard to deliver high quality data mappings from multiple heterogeneous data sources that have variable quality across the whole of the health domain. It's a massive subject matter domain, and that we should agree on and focus on high value data sets so that we can concentrate the education, the skills, and the efforts in the capture of high quality, high value data. We should be able to promote standardized mappings and semantics to common data models for these data sets. I put the little S after data models in brackets. You probably remember hearing from Peter Reinbeck early this morning about the OMOP common data model. It's not my place to say we should have one data model, but let's not have large numbers of common data models or we won't solve the problem. And then once we've done that, we can develop standardized analytics and tools to process these data for multiple purposes, because we've also got to have consistent analytic methodologies, which is a point I know that Miriam may have made in a session earlier today. So calls to action on this topic. The European Commission must coordinate. I think the Commission has to be the coordinating body, but it's not the main domain actor. We need to see coordination of multiple stakeholders from healthcare, public health, research, and patients to develop high value data sets that respond to the most urgent knowledge discovery needs. And then multiple healthcare and research funders need to be prepared to co-finance the development of the corresponding standards with the SDOs, their adoption into products, the upgrade of deployed systems, and the training of professionals and patients to ensure that we have standardized, high quality, high value data for all. We've got to start somewhere. Let's start with high value data. Then to the EHDS, a few points here that came up. Data quality labeling is specified in the EHDS regulation for primary use by EHR systems and for secondary use in terms of data sets. But actually, the way that the regulation specifies what data quality means for primary and secondary use are different. And yet we know that most of the influences on data quality are at the point of capture. It was also noted that fair metadata isn't explicitly emphasized, but it is something that the entire global community is rallying around. And we would like to see the EHDS more formally specify the importance of this. The other thing that I would like to raise, and this may be a bit more personal than arose in the meeting, but in addition to the fair metadata, the clinical research sector needs standardized descriptions of data set content. This is going beyond fair. What kind of patients are in the data set? What diseases, what categories of health information can I find in a data set? So I really know if I'm looking to do work on pediatric neurofibromatosis, that your data set has data on children. Do you have CSF analyses? If you don't, it's not worth my while bothering with your data set. That's going a little bit beyond, but we need to see data catalogs, including that kind of data. An example, and again, I'm only offering as an example, the Eden catalog contains this kind of information. Now, the secondary use sector is charged with sorting out the labeling of data sets, but they can't scale the capacity to labeling a massive range of data sets. And I suspect it's even more challenging for the secondary use sector to get involved in this when they're dealing with large-scale federated networks. And so it's likely that the burden of labeling is going to fall on the primary use sector, with which they're not equipped either in terms of skill or capacity, resources. So firstly, calls to action. The EHDS regulation must better align primary and secondary use data quality expectations and labeling. The implementing legislation, which often follows a regulation, must standardize that data quality labeling, to include data quality, fair metadata, and contact characterization in the kind of clinical content way that I described. And the EC cannot just do this autocratically. You've got to consult with the ecosystem stakeholders who are already very familiar with how to do these things, so that the implementing legislation captures the best of breed, state-of-the-art knowledge that experts have around Europe, because indeed we do have those experts. And then all actors in the data flow pathways from the initial point of data capture through to its longer scale reuse, they've got to have the capacity and the competence to add their part of context to the data set labels. And they're going to need incentives to do this. So we've got to look not only at asking the data source at the point of data capture to begin the labeling process, but almost a snowballing of labeling data needs to be added as the data travels. And we need to look at how we achieve that. My last few slides are relating to patients. I will check my email to see if I've received any last minute points from others. But basically, the critical thing I want to say here is that for patients, it's really important. I've used these 4 keywords: inform. Still, far too many patients don't understand who uses and reuses health data, possibly including their own health data. Why do they reuse health data, and what benefits do they bring? Patients also need to better understand the safeguards around them. What is the data protection rights that they have? How can data be protected? And how actually is it protected in practice? And if they're being asked about data reuse themselves to give permissions, what should they look for to give them assurance that the party who wants to use their data is going to protect them while they're using it? Patients must be more engaged in the whole health data ecosystem. They must not be seen as the passive, give your data and then we're going to run away with it. No, they must be inside the loop. And there are a whole bunch of channels that we should be leveraging in order to help bring them more solidly on board. And finally, let's really value patients as data partners. And here then my call to action, what do I mean by data partners? Firstly, the health ministries, health insurers, and the health data reuse industry sectors, that means pharma, medtech, big tech, and so on, must join forces and be co-investors in educating and empowering patients. Firstly, to capture their own data to a high quality, because most patients know nothing about data quality, but we're going to rely more and more on their data in the future. Secondly, patients are a powerful force to lobby for and help ensure high quality of their professionally captured health data. Patients can, for example, see their own records and can highlight if there's an error that they can detect, a missing condition, or a drug dosage inconsistency. They must have channels to enable their health data to be reused for purposes they support, because we know that if patients really are empowered and engaged, the vast majority are supportive of health data reuse for purposes that bring benefits back to healthcare. Doesn't have to be benefits back to them. There's a lot of generosity in the public that we must really recognize and value. They are happy for their data to be used for benefit of others, if not themselves, if you engage them in the right way. And they've got to also get feedback. It's unreasonable that patients give data or allow data or give permission to give data, or even aren't asked for permission but don't object to their data being used in an opt-out kind of model, and that they don't learn about what's happened. So generating societal benefits. And the second is that initiatives like Data Saves Lives, about which I hope everybody in the audience knows, must be scaled up within countries as well as at EU level. And they need to shift towards more infrastructural funding for this. It's no longer something that should be supported in a piecemeal way, which I know is currently, generously supported. I don't mean to say they don't have good funding, and I'd like to thank the sponsors of Data Saves Lives, whom I often know. But I really think it needs to shift to more infrastructural funding to help this happen. Now, I haven't got feedback on the last three panels that have happened, and I'm sorry for missing out on you, but please see this as very hastily constructed slides put together really quickly. So I've not done justice to all of you in the room who've been part of sessions, and I'm sorry for that. But this is at least my best effort to try to put together a story that can lead Mats nicely into an interesting panel discussion. But I wanted to close with a final remark, if I can, because everything I've heard from a distance, from not in Portugal, tells me that you are together highlighting important enough position statements and calls to action that we have a good chance of developing, agreeing, and promoting on a Porto declaration of health data quality, using some of the material in my slides, using the notes that have been captured from the sessions, and we'll listen back to the recordings of the keynotes later and capture notes from them. But I would like you to really indicate, and I can't see what you're thinking, but Mats has promised to look at your faces. Do you think we have enough of a momentum and achieved enough insights in this event that we could work between now and Christmas on a draft Porto declaration of health data quality to share with you all, see what you think in January, and then see if you would be willing to let your organizational logo be on a declaration? I'd be grateful for your feedback, but I can't see your feedback. So Mats, Paul, you're looking at the audience, I hope. Are you seeing smiles or frowns? I finished my presentation here, but I'd love to know.
It's I think mixed reactions, but excitement as well as concerns on the challenge that you have placing. But Mats is now joining us here, and he's going to be in the session here at the table with us. Good. Mats has a time constraint, so I'm trying to make sure that he's not leaving the bus, missing his flight tonight. So we are not going to stop the live stream. So it's going to be both the